Hello and welcome. Today, we're diving into a rare but important neurological disorder, Kennedy's disease, also known as spinal and bulbar muscular atrophy, or SBM. We'll explore what causes it, how it affects the body, and what options are available for managing this condition. Kennedy's disease is caused by a mutation in the androgen receptor, or R gene. This gene provides the instructions for making a protein called the androgen receptor. The mutation involves an abnormal expansion of a DNA segment called a CA repeat within the R gene. Individuals with Kennedy's disease have an excessive number of these CA repeats. Since the AR gene is located on the X chromosome, Kennedy's disease is an linked recessive disorder, primarily affecting males. Women who carry the mutated gene are usually asymptomatic or have very mild symptoms. Now, let's delve into the pathophysiology. The mutated AR gene produces a faulty androgen receptor protein. This abnormal protein accumulates within motor neurons, which are nerve cells responsible for controlling muscle movement. The buildup of this protein disrupts the normal function of these neurons, leading to their gradual degeneration and death. This process affects both the spinal cord, hence spinal, and the brainstem, specifically the bulbar region, hence bulbar, resulting in the characteristic muscle weakness and atrophy associated with the disease. Androgens like testosterone bind to this mutated androgen receptor. This binding further exacerbates the toxicity and aggregation of the protein, contributing to the disease's progression. This explains why males are more severely affected. Kennedy's disease is considered a rare disorder. Its exact prevalence is difficult to determine, but estimates suggest it affects around 1 in 30,000 to 50,000 males worldwide. Because it is a linked disorder, it is more commonly diagnosed in males. While it occurs across various ethnicities, accurate epidemiological data remains limited. The signs and symptoms of Kennedy's disease typically manifest in adulthood, usually between the ages of 30 and 60. The most common initial symptom is progressive muscle weakness and atrophy, primarily affecting the bulbar muscles, those controlling speech, swallowing, and facial expressions. This can lead to slurred speech, difficulty swallowing, a dysphagia, and facial muscle twitching or weakness. Limb weakness, particularly in the arms and legs, is also a prominent feature. This can result in difficulty walking, climbing stairs, and performing fine motor tasks. Other symptoms may include muscle cramps, tremors, fatigue, and sensory disturbances such as numbness or tingling in the extremities. Due to the role of the androgen receptor, affected individuals may also experience endocrine abnormalities, such as gynecomastia and enlargement of breast tissue in males, reduced fertility, and erectile dysfunction. Diagnosis of Kennedy's disease involves a combination of clinical evaluation, neurological examination, and genetic testing. The presence of characteristic symptoms, such as bulbar and limb muscle weakness, along with a family history of the disorder, may raise suspicion. Electromyography, or EMG, which assesses the electrical activity of muscles, can help identify motor neuron dysfunction. The definitive diagnosis is confirmed through genetic testing, which detects the expanded SOD repeat in the AR gene. Blood samples are commonly used for this genetic analysis. Kennedy's disease doesn't typically have sub-classifications or distinct types, but rather presents a spectrum of severity. The age of onset and the rate of disease progression can vary between individuals, even within the same family. Some individuals may experience a slower progression with milder symptoms, while others may have a more rapid and debilitating course. Unfortunately, there is currently no cure for Kennedy's disease. Treatment focuses on managing the symptoms and improving the quality of life for affected individuals. Physical therapy can help maintain muscle strength and mobility, preventing contractures and improving balance. Speech therapy can address speech and swallowing difficulties. Occupational therapy can provide adaptive equipment and strategies to assist with daily living activities. Medications, such as anti-tremor drugs, may be prescribed to alleviate tremors. Hormone therapy may be considered to address endocrine abnormalities. Assistive devices, such as walkers or wheelchairs, may become necessary as the disease progresses. Regular monitoring by a neurologist and other specialists is essential to adjust the treatment plan as needed. As Kennedy's disease is a genetic disorder caused by a mutation in the AR gene, there is no known way to prevent it from occurring in an individual. However, genetic counseling is crucial for families with a history of the disease. Genetic counseling can help prospective parents understand the risks of passing the mutated gene to their children and explore reproductive options, such as preimplantation genetic diagnosis of PGD or prenatal testing. The prognosis for individuals with Kennedy's disease varies. The disease is slowly progressive, and most individuals maintain the ability to walk, although with increasing difficulty, for many years after diagnosis. However, the progressive muscle weakness and atrophy can significantly impact their quality of life. Respiratory complications, such as aspiration pneumonia, can occur due to swallowing difficulties. Research is ongoing to develop effective treatments for Kennedy's disease. Recent studies have focused on strategies to reduce the accumulation of the mutated androgen receptor protein in motor neurons. Some research has explored the potential of gene therapy to correct the underlying genetic defect. Clinical trials are currently underway to evaluate the safety and efficacy of new therapeutic interventions. The future holds promise for improved treatments and, potentially, a cure for this debilitating disease.